Okay, so this afternoon we've been called to a 70-year-old gentleman. On our arrival, he's actually sitting in a lazy boy. He has chest pain and has had a collapse today. The onset of chest pain was sudden and or acute. He's unable to stand and feels like he's going to faint and he's dizzy. He had an MI 5 years ago. The chest pain he currently feels is different to his MI from that time. He's pale and clammy, his eyes are open to voice, mildly confused. Patient, he's sitting in a lazy boy. He feels palpitations going into his neck and his heart. Feels like his heart's going to jump out. He's on Cilazatil and aspirin. Current vitals 170 heart rate, BP is 70/40, respirate is 18, blood glucose is 7.6 and temperature is 37. So when we first arrive, we need to get a full set of baselines for this gentleman. We're going to feel his pulse, and while we're doing that, you can feel his skin. So he does feel clammy, looks clammy, quite diaphoretic. His pulse is strong and quite rapid. So Jenny's going to put some leads on, do blood pressure, SpO2, and we'll try and get a 12 lead off, and then decide where we go from there. The lead's going on. Okay, so looking at that rhythm there, that's it's very broad, very fast. That looks like VT. So at this point, whilst we would be assessing the patient's level of compromise, and looking at this patient, he's got central chest pain, he's got a slightly altered GCS of 13, he's hypotensive, tachycardic, and we would class this patient as status 1. We need to think about differential diagnosis as far as what this rhythm could actually be. The initial view, it looks like it's a ventricular tachycardia. The patient is conscious, so conscious VT. We need to think that this could possibly be a supraventricular tachycardia, or SVT with aberrancy. The aberrancy being some form of heart block, bundle branch block, which could mimic making this rhythm look wide and mimic the VT. With this person's level of compromise, we're going to call this VT. The fact that he is severely compromised, we would call for an R50 for backup. This patient, the possibility that he will deteriorate and arrest, so we call the R50 for that reason, and to help us with some drug interventions if required. So here's the patient that we lay the patient supine. We're going to attach some defibrillator pads, getting ready to shock this patient. I'm going to gain IV access and administer some analgesia. Just quickly before we do that, we're going to make sure that we've got quick access to our equipment if we're going to need to resuscitate this patient, and I'm going to look at getting some access quickly. So we can say that we have obtained IV access. Our drug of choice for analgesia here would be fentanyl. Preparation for fentanyl comes in 100 micrograms in 2 mils of fluid. So we would draw up 8 mils of saline, and then draw up the 2 mils of fentanyl, making 100 micrograms in 10 mils of fluid. And we would administer 50 micrograms as an initial dose, just to help with analgesia, as the cardioversion can be quite painful. So once we've administered that, we've got our full set of baselines, we've got our pads attached. We're going to turn to our cardioversion checklist and just work through that to make sure that we've got everything prepared properly. So we've placed our pads. Our pads are in the apex and sternum position. We're going to ensure that the defibrillator is in manual mode, which it is. We're going to select a lead and look for the highest R wave, which on the MRX we've got our 1 lead. We're going to press a synchronise button.
Okay, synchronise button pressed.
Thank you. And we're looking for to confirm the detection symbol above the QRX complex,
yes,
which we
that's
have.
Confirmed.
Yep, and that's nicely synced there. We're going to ensure the patient has received adequate analgesia, and we've talked to the patient about the procedure and warned them. we're going to select the maximum joules. We're going to turn it around to 200 on this machine, and we're going to press the charge button.
Pressing the charge button.
Thank you. Then we're just going to make sure that everybody's clear. We're all clear.
Clear.
Everyone happy?
All
Yep.
clear.
Shock when you're ready. Hold the button down for us. Hold that button down to make sure that that has gone through. That's great. That's gone through. Held the shock button down. We're now going to determine our rhythm, and that looks like a nice, clean, clear sinus rhythm. And the rate is dropping nicely. We're down to 80 beats per minute. We'd obtain another full set of vital signs now. If the patient didn't revert after that first cardioversion, then we would run through the whole procedure again, run through our checklist again to make sure that we've got everything covered, and then we would cardiovert again. This patient has reverted back to a sinus rhythm. The fact that they were in VT to start off with and severely compromised, we would pack this patient and take them off to the nearest ED for further assessment.